For decades, we thought we knew the rule for treating one of the deadliest conditions in medicine. You have to act fast. But what if, for a whole lot of patients, that rule is actually wrong? Today, we're diving into some fascinating new research that uses artificial intelligence to challenge a core belief of emergency medicine. And it reveals a much more nuanced and maybe even safer way forward.
Okay, let's just start with this central question. Picture yourself in the ER with a really bad infection. How fast do you need antibiotics to save your life? I think most of us, right, we would shout, immediately, as fast as humanly possible. And that makes sense. But it turns out
the answer isn't always immediately. I know, it sounds kind of crazy, but a groundbreaking study is suggesting that for a huge number of patients, a more measured approach might be just as effective. And get this, it could help us fight that other massive global crisis, antibiotic resistance. So yeah, this is the mystery we're unpacking today.
To really get why this is such a big deal, first, we need to understand the stakes. We're talking about the very real, very urgent race against sepsis.
Every single year, just in the United States, sepsis is responsible for more than 350,000 deaths. That is a staggering number. It's a leading cause of death in our hospitals, a huge driver of healthcare costs, and a condition where, honestly, every single decision is absolutely critical.
All right, so now let's try to put ourselves right in the shoes of an ER doctor, because they are faced with a constant, incredibly high-stakes dilemma.
First off, what even is sepsis? It's a little confusing. It's not the infection itself that's the main problem, it's the body's overwhelming, life-threatening response to that infection. Your own immune system basically goes haywire. It's trying to fight the germs, but it ends up damaging your own tissues and organs. And that, of course, can lead to shock, organ failure, and death.
So you can see how this puts doctors in a really terrible bind. On one hand, the official guidelines push for an act-fast approach. Give antibiotics within hours if you even suspect sepsis. But the problem is, this leads to massive antibiotic overuse, which is fueling those deadly superbugs we all hear about. The alternative is to wait and see, but in that time, a patient could get much, much sicker or even die. It's this awful trade-off, and it's based almost entirely on a doctor's gut feeling.
The way it works now, doctors have to mentally sort patients into one of 4 boxes based on 2 very subjective questions. Is sepsis possible or is it probable? And is the patient in shock or not? The huge problem here, and what the research really highlights, is that 2 doctors could look at the exact same patient and choose different boxes. And that could lead to completely different treatments. There just had to be a better, more objective way.
And that is exactly where this new study comes in. Researchers decided to train an AI to act as a kind of data-driven, objective diagnostician.
Probably the best way to think about it is like this. A normal fire alarm, right? It can't tell the difference between you burning toast and the whole house being on fire. It just screams. That's kind of like the old treat everyone fast approach. This AI, though, it's like a smart fire alarm. It uses thousands of data points to figure out the difference between a little smoke, a low-risk patient, and a 5-alarm fire, a patient who is truly, truly in danger.
So how'd they build it? Well, they took the electronic health records from over 34,000 patients, a massive amount of data. Then, they used that data to train 2 separate deep learning models. The first one, called Composer, its job is to predict the probability of sepsis. The second one, ShockNet, predicts how likely it is that the patient will go into septic shock. Together, these models objectively place each patient into one of those 4 risk groups, but using hard data, not just intuition.
So, with the AI sorting patients objectively, researchers could finally test that core question. What really happens when you give antibiotics at different times to these specific risk groups? And what they found led them to rethink the entire idea of the sepsis clock.
The results were just stunning. The AI sorted patients into groups with wildly different outcomes. I mean, just look at this. The highest risk group, where sepsis was probable and shock was likely, had a staggering 23% mortality rate. But then you go all the way to the lowest risk group, their mortality rate was just 1.9%. This objective sorting was the key. For the first time, researchers could see these clear, data-driven risk profiles.
And based on that data, the researchers came to this really powerful conclusion, especially for that low-risk group 4. They found that for these patients, waiting longer than the standard 1 or 3 hours to give antibiotics, it didn't change their mortality rate at all. This suggests, in their words, that a more lenient approach is safe, and it buys doctors precious time for more testing.
But, and this is so critical, the AI also confirmed when the clock absolutely does matter. For patients with probable sepsis, the data showed that getting antibiotics in under an hour was associated with lower mortality. So this isn't about throwing out the clock entirely, not at all. It's about knowing precisely which patients are in that desperate race against time.
So what does all this mean for the future? Could this research actually lead to a completely new standard of care?
This is why this could be a total game changer. That lowest risk group, the possible sepsis, shock unlikely patients where a delay was safe, they weren't some tiny fraction. They made up approximately 40% of all patients with suspected sepsis in the study. That is a massive opportunity to safely reduce unnecessary antibiotic use without harming a single patient.
And that really leaves us with this final thought. For years, we've seen treating the individual patient and fighting the public health crisis of antibiotic resistance as a trade-off. But what this explainer shows is that with better, data-driven tools, it might not have to be. We may be entering an era where an algorithm can help us do both at the exact same time.